Welcome. My name is Parikh. I'm a nephrologist and division director of nephrology at Johns Hopkins University, and I'm joined by Malhotra, a fellow nephrologist, and Heather Thiessen Philbrook, a biostatistician. I also direct the Data Science and AI Center for the Department of Medicine. Today, we are sharing with you the results from a recent CJSN article on a practical tool designed to help clinicians predict kidney graft failure in transplant recipients. The model uses changes in estimated GFR over time and the risk updates whenever a new laboratory result becomes available. The risk estimates change based on recipient's kidney function trajectory rather than remaining fixed at a single time point. Our aim is to find patients who need more attention sooner and free clinical resources for those at greatest risk. The model is built to fit into routine practice because it uses data already present in electronic record and can be applied at any time during the first 3 years after transplant. By updating the risk estimate as new kidney function tests are measured, the tool can identify patients who are likely to remain stable and those whose risk is rising, which supports more tailored follow-up. For patients judged to be at low risk, the transplant centers could consider shared care with primary care physicians or community nephrologists, while higher risk patients can receive intensified monitoring and earlier interventions.
In practice, this means we can prioritize clinic visits, order targeted tests sooner, and adjust medications earlier when the predicted risk increases. And we can also consider biopsy or enhanced surveillance for infections and non-invasive markers when indicated. The tool gives an objective measure to guide conversations with patients and to support shared decision-making, and it may help transplant programs allocate resources more efficiently.
For each patient, we estimate individual trajectories of kidney function and then use those trajectories to predict 3-year graft failure. Kidney function measurements are routinely completed in recipients, so the predicted risk can be easily calculated and updated as new measurements become available. In the development group, the model showed improved accuracy over time as more laboratory measurements accumulates. External validation showed lower early accuracy when laboratory measurements were sparse, but discrimination improved as more data were available, underscoring the value of frequent and reliable testing.
The strengths include ease of implementation and use of real-world data, while limitations include reliance on serum creatinine to estimate kidney function. We plan to pilot the tool in routine care to study whether it changes clinical decisions and outcomes, and to explore adding rejection events, proteinuria, and other time-varying measures to improve early prediction.
This model turns routine laboratory trends into timely clinical signals that help us focus care where it matters the most. Thank you to the team and to the study participants who made this work possible.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.